Hi everyone, Dr. Sylvestre here. I had a talk with Dr. Nancy Brock, board certified anesthesiologist, and I bet you she is going to surprise you about what she had to say regarding pre-anesthetic blood work and the use of opiates. Have a listen.
Nancy, further to your approach to anesthesia in general practice in a way that it can be streamlined, simplified, and made very safe, what else would you like to say to general practitioners?
Um, I would like to bring everybody back to the central theme that it goes over like a lead balloon when I say this, but I'm going to say it anyways. It's not about the drugs. It's about having a calm patient. It's about knowing your patient's health status. It's about paying attention. There are also things that we in general practice do that I think complicate our lives without necessarily making anesthesia more safe. There are two examples of that. One is, and it's not all the time that people do this, but when you have a patient scheduled for surgery, to be doing investigative diagnostic tests like blood tests and urine tests on the day of surgery. It's unnecessary. Granted, there will be times when that's the way things have to be done for myriad reasons, but if it's at all avoidable, I would have a patient in a week ahead of time. The blood work test results don't need to be same day, but also you have an opportunity to look at the test results, interpret them, talk to your clients, and think about whether or not your timing for the procedure is correct. And this all happens on a day other than surgery day, because surgery time is precious. It needs to be protected. If you have a patient scheduled for surgery, the surgery needs to happen that day. So that's one example. And the other example actually, it brings up the topic of opioids in pre-medication. And my bias, I'll just say, my bias is to use butorphanol as my pre-medication unless I have a compelling reason not to. And the compelling reason not to use butorphanol in the pre-med is a patient that is in acute pain already. And I emphasize acute pain, not chronic.
Okay. So not I ruptured my cruciate 2 weeks ago, and now I'm getting my surgery today. Or let's be real, I ruptured my cruciate 6 weeks ago, and I finally got the surgical appointment today, right?
Yeah. What I'm thinking about is the patient that has broken its leg.
Right.
That is the acute pain I'm trying to speak to. In that instance, I reach for something other than butorphanol. And in that instance, I will reach for methadone, or I used to reach for hydromorphone, but I'm on a mission now to try to get people to stop using hydromorphone if they can. Obviously, drug shortages make it so that we have to be somewhat nimble, but methadone has a way of giving you predictable, effective, altered mentation without the nausea and the vomiting and the GI upset.
Is that the main advantage of methadone over hydromorphone? The side effects, the vomiting, the nausea,
Well, that's one of them. The other is somewhat subjective and qualitative. And my observation is that the quality of the opioid-induced pre-med with methadone is less likely to lean towards dysphoria. So you're less likely to have a dysphoric patient. If you're going to have a patient that is phoric in some way, it'll be euphoric. And that's actually quite different from dysphoric. From an anesthesia point of view, I much prefer to work with a euphoric patient than a dysphoric. The dysphoric patient I have to chase. The euphoric patient I can work with.
Okay.
So
interesting. And tell me, what do you see when the patient is euphoric versus dysphoric? What do you see as the anesthetist?
The patient is happy, very, very happy.
Wagging his tail?
Yeah, and just facial expressions are reflective of a
Yeah.
happy state. I mean, I'm using terms that somewhat lack in their medical application, but it's just what I see. A dysphoric patient is a panting fool,
Yes.
and it has a strained look on its face, and I think the strained look that I see is nausea.
So Nancy, when you talked about using butorphanol over an opioid, I always thought butorphanol was an agonist antagonistic opiate. Am I wrong?
No, you're right. It absolutely is. But it is the best, in my opinion, the best sedating opioid that I have in my toolbox. And so at the time of pre-medication, calming and sedation are my goals, my therapeutic goals. And so I will reach for butorphanol as much as I can. Any patient that comes to me that is not in acute pain gets butorphanol as part of the pre-medication. But I know that anesthesia just doesn't happen for its own sake, that anesthesia is delivered to a patient in order to do surgery, and that involves pain.
Yeah.
So if we circle back to the butorphanol decision-making where it was given in the pre-med, there is concern that somehow that's going to provide less than adequate analgesia. And I want to disabuse people of the idea that if they start with butorphanol, that they can't migrate to something else in the perioperative period. As a matter of fact, I do that routinely. I will start with a butorphanol component pre-medication to get the calming effect. And I will then go into surgery where there's going to be acute pain delivered. And by then, I have administered my pure mu opioid agonist analgesic intravenously. And I'm not concerned about the butorphanol that I gave in the pre-med for two main reasons.
Tell me.
One reason why this mixture of pure mu opioid that follows the opioid agonist antagonist is that there's timing involved. So the butorphanol is given and then time goes by. So the butorphanol is starting to wear off, and dosing. The dose of butorphanol that I use is 0.2 milligrams per kilogram mostly, and that's an extremely low dose.
Okay.
For
That's
dogs
right.
and cats.
Dogs and cats. Okay, thank you. And yeah.
Yeah.
0.02 milligrams per kilogram, you said.
0.2.
0.2. Thank you.
0.2. And then I'll follow up with, if you want to follow up with hydromorphone, go for it. If you want to follow up with methadone, go for it. They all play nice in the sandbox.
That's good to know. What kind
Yeah.
of time frame would you be talking about that would be adequate?
Half an hour.
Okay, well, by the time even if you're incredibly fast at prepping, by the time you've induced, put your IV, or not induced, but given your pre-med, placed your IV catheter, prepped the patient, moved into the OR, draped, scrubbed, draped.
Yeah.
That's
the concern is academic,
It is.
I understand. Is academic.
Yeah. I understand that now. Yeah, to me that was always a big deal. Oh no,
don't. Yeah, for me too.
Yeah. Very interesting.
You can subscribe to this channel for more information from Nancy Brock.